Hello everyone. Today we are going to study one of the important topic of third year BPT students is dislocation of dislocation of shoulder. Okay. Before start reading about the dislocation, we will go to the anatomy of the shoulder joint. Anatomy of the shoulder joint. We all know that the shoulder joint is a ball and socket. Ball and socket joint, which provides mobility of the whole upper extremity. In all direction. So that's why it is the most common dislocation among the most in human body. You will say the most common dislocation is the dislocation of shoulder due to all directional movement. Multi-directional movement, the mobility as in case of upper extremity, the mobility is more important than the stability. So the joint is formed by the very shallow glenoid cavity. Okay, shallow glenoid cavity in which the small portion of head of the humerus, small head of the humerus, okay, lies. The joint is surrounded anteriorly. Joint is surrounded anteriorly, superiorly, and posteriorly by the musculotendinous cuff. That is the rotator cuff. Okay, anteriorly, superiorly, and posteriorly by rotator cuff or the musculo tendinous cuff, mainly by the what are the muscle rotator cuff? Supraspinatus, infraspinatus, subscapularis, and teres minor. These four muscles surround the shoulder joint. The muscle together with the bigger muscles such as the pectoralis and latissimus dorsi, which also helps to retain the head of the humerus to the socket that is the glenoid cavity. Okay, so the inferior aspect of the capsule is unsupported by the muscles. Inferior aspect, that is the axillary aspect, which is unsupported by any of the muscles, and which is the inferior aspect is the weakest part of the shoulder joint. Okay, inferior aspect is the weakest part of the shoulder joint. Now we come to the main part, that is the dislocation of the shoulder or shoulder dislocation. Now we have to study about what is dislocation. There are two terms in the orthopedic, mainly is the dislocation and another one is subluxation. Okay, dislocation and another part is subluxation. Here, what do we mean by the dislocation? Okay, what do we mean by the dislocation? Here we will say a joint is dislocated when its articular surface are completely displaced. Here the articular surface means the glenoid cavity from the head of the humerus is completely displaced one from the other. So here the term important is the completely displaced, that is the dislocation. And the subluxation, a joint is subluxed when its articular surface are only partially displaced. One from the other. Here the term differentiate from the dislocation from the subluxation is the dislocation is the completely displaced, it is partially displaced. Where now we'll see the most common dislocations among the different joint. Common dislocation of different joint are: number one, most common is the shoulder dislocation. Okay, hip dislocation, spine, elbow, so wrist Okay, metacarpal joint, knee joint, and the most commonest is the shoulder dislocation. Okay, so next we'll go through the shoulder dislocation. Here we'll study the shoulder dislocation. The in shoulder dislocation there is classification of shoulder dislocation. In the classification of shoulder dislocation, there are most three types of shoulder dislocation occurs. Number one, anterior shoulder dislocation, which is the most commonest dislocation among the body in the shoulder dislocation also. Okay, this is the commonest dislocation among the body. Number two is the posterior shoulder dislocation, which is very rare. And number three is the inferior dislocation. Here the another name of the inferior dislocation is luxatio erecta. Luxatio erecta. This is the another name of the inferior dislocation. Next we will study the mechanism of shoulder dislocation. Mainly a fall on a outstretched hand. Okay, fall on a outstretched hand with the shoulder abducted and externally rotated. Is the common mechanism of injury. Fall on an outstretched hand with shoulder abducted and externally rotated is the most common mechanism of injury. Now we'll know about the pathoanatomy. The classification are the number one is the anterior shoulder dislocation. Anterior shoulder dislocation. Here the injury in the anterior shoulder dislocation, the head of the humerus comes out of the glenoid cavity, and it lies anteriorly. Okay. In this case, the anterior shoulder dislocation, it is further sub-classified into three categories. Number A is the preclinoid type. Number B is subcoracoid. Number C, subclavicular. In the preclinoid type, the head of the humerus lies in front of the glenoid cavity. Head lies in front of glenoid cavity. In the subcoracoid type, it lies below the coracoid process. So that's why it is known as the subcoracoid. Sub means below the coracoid process of the scapula. It is the commonest among the subtypes. This subcoracoid type. The subcoracoid type is the commonest, and the subclavicular head lies below the clavicle. Below the clavicle. Okay. Now here we'll go through the three subtypes: the preclinoid type, subcoracoid type, and the subclavicular type. So see, this is A, is the preclinoid type. This one is the preclinoid type. This position, number B position here, is the subcoracoid type under the coracoid process. When the humeral head is under or inferior to the subcoracoid process, this is the subcoracoid type of anterior shoulder dislocation. And this is the infra or subclavicular type. Infraclavicular type or subclavicular type. Here the head of the humerus lies below the clavicle. See, from this we'll know this is the normal shoulder anatomy. Here anterior dislocation, the anteriorly displacement of the humeral head from the glenoid cavity is the anterior dislocation, and this one is the posterior displacement of the humeral head, is known as the posterior dislocation. Okay. Now number B, number 2 is the posterior dislocation of the shoulder joint. In this injury, the humeral head, the head lies posteriorly. Humeral head lies posteriorly or behind the glenoid cavity. Okay. Lies behind the, and number 3 was the inferior dislocation or luxatio erecta. It is the but it is a rare type of dislocation where the humeral head comes to lie in the subclinoid position or inferiorly. The head lies in the subclinoid or below the glenoid, subclinoid position. Okay, now we'll study the pathological changes occurs during the dislocation. Or pathoanatomy, you can say. Okay, and the pathological changes, firstly there is changes in the capsule or labral, capsule and labrum, changes in the capsule and labrum, that is known as the capsulolabral injury. Okay, here mainly the anterior capsule of shoulder joint is torn. Mainly the anterior capsule is torn. Next, the inferior glenohumeral ligament stressed or ruptured. Firstly, the anterior capsule is torn. Secondly, the inferior glenohumeral ligament, which is overstretched or ruptured. Next, there is detachment of glenoid labrum from the anterior rim, which is also known as Banker's lesion. Which is also known as Banker's lesion. See, this is the Banker's lesion. This is the normal labrum. This one is the normal labrum, and this is the torn labrum, that is known as the Banker's lesion. Okay. This is the glenoid cavity. The glenoid labrum is attached to the glenoid cavity, and this one, there is, due to dislocation, there may be tear in the glenoid labrum. When there is detachment of this glenoid labrum from the bony portion, that is known as the Banker's lesion, which mainly occurs anteriorly. Okay. Next, this was the capsulolabral changes occurs, or pathological changes, or you can say pathoanatomical changes during the injury. That number 2 will be the bony lesion. In the bony lesion, firstly there is the heel satch lesion. SACH, Hill-Sachs lesion. Here in the Hill-Sachs lesion there is compression fracture on posterolateral humeral head. Okay, that is a bony lesion or Hill-Sachs lesion. Hill-Sachs lesion when there is compression fracture on the posterolateral humeral head. See, this is the posterolateral humeral head where there occurs the humeral head impacts the anterior glenoid rim. Okay, due to this lesion here the compression fractures occurs at the posterolateral humeral head, that is known as the Hill-Sachs lesion. It occurs when humeral head impacts anterior glenoid rim. One number 2 after the Hill-Sachs lesion is the bony Pankhurst. This was the labral Pankhurst when there is detachment from the glenoid labrum from the anterior limb. This one was the and there another one is bony Pankhurst. What is the bony Pankhurst? There is fracture of antero inferior glenoid rim. This is here. See, there is a fracture in the antero-inferior glenoid rim. That was the posterolateral was the Hill-Sachs lesion, and bony Pankhurst was the anterior inferior glenoid rim. In the pathoanatomical changes, number 1 was the capsulolateral injury. Under the capsulolateral injury, the Pankhurst lesion occurs. Number 2 was the bony lesion. In the bony lesion, there was the Hill-Sachs lesion and bony Pankhurst. Now we'll go to number 3 was the muscle and tendon damage. Mainly in case of shoulder dislocation, the subscapularis tendon may stretched or torn. Which tendon? The subscapularis tendon may stretch or torn. Sometimes in case of elderly, the whole rotator cuff the whole rotator cuff may tears. The whole rotator cuff in case of elderly patient. Okay. Now next point on the pathoanatomy is the neurovascular involvement. In case of shoulder dislocation, there is maybe axillary nerve injury, which is the most common axillary nerve injury. In case of axillary nerve injury, due to this, there may be loss of sensation over the regimental batch area. What is the regimental batch area? In case of army, the batch were at the regiment, that region is known as the regimental batch area, where the army were the batches. And another one is there may be deltoid muscle weakness, because the deltoid muscle is supplied by the axillary nerve. Okay. Next, the neurovascular in changes. There may be rare, which is rare, is the injury to posterior circumflex artery. Okay. Next we'll go to number 5 is the joint changes. Or you can say that relationship between the joints changes. Here in case of shoulder dislocation, the humeral head displaced antero-inferiorly. The glenoid cavity is empty. And there may be loss of normal concavo-convex stability. Okay, so these are the pathoanatomical changes during the shoulder dislocation. Next we'll go to the clinical features of the shoulder dislocation. In case of shoulder dislocation, firstly there will be severe pain. Okay, the pain will be exaggerated along with the dislocation. Next, there is loss of shoulder contour. There will be loss of shoulder contour. The shoulder will be square shoulder. Squared shoulder. Squared shoulder means, see, normally the shoulder is rounded. See here, the shoulder is rounded, and this one is, see, square shoulder. This one is normally rounded shoulder. Okay, so this shoulder will be flattened and rounded. Next will be the arm held in slight abduction and external rotation. See, the arm is abducted and externally rotated. Okay, this when the patient comes in this position, there is the shoulder dislocation. This is the clinical appearance of the shoulder dislocation. Patient comes with the rounded shoulder, not flattened shoulder or square shoulder, along with the arms abducted and externally rotated. And next will be the prominent acromion process. You will not see here the acromial process will be prominent, but here the acromion process is prominent here. Okay. Next, prominent acromion process, and lastly there will be restricted movements along the shoulder. So these are the clinical features of dislocation of shoulder. Next, the diagnosis. In diagnosis, we may diagnose through X-ray. Okay, and next diagnosis through the on examination. What are the clinical tests in examination? Number A is Dugas test. What is the Dugas test, or when we will say the Dugas test is positive? When there is inability to touch the opposite shoulder. When the patient is unable to touch the opposite shoulder with the hand, that means the Dugas test is positive. Okay. Next test is the Hamilton ruler test. What is the Hamilton ruler test? The ruler or scale, you can say, the ruler touches both the acromion process and the lateral epicondyle. of humerus. See, in Hamilton ruler test, one ruler is placed here. When the ruler touches both the acromion process with the both the acromion process ruler touches both the acromion process and the lateral epicondyle of the humerus, then the test is positive. Normally, when we will place the ruler here in the normal side, okay, this is the normal side, the ruler cannot touch the acromion process is here. If you place the ruler here, the acromion ruler will not touch the lateral epicondyle and the acromion process. When there is dislocation of the shoulder, if you place the ruler here, it will touch the acromion process and the lateral epicondyle of the humerus. Okay. Next, we will go to the treatment. In case of treatment, in acute dislocation of the shoulder, at first reduction is done. Okay, reduction. The reduction is done either under sedation or general anesthesia. Okay, followed by immobilization of the shoulder in a chest arm. Bandage. For how many weeks? At least 3 weeks. Okay. So next, there are some reduction techniques. We'll study the reduction techniques or techniques of reduction. There are 3 types of reduction. Number 1 is Kocher's reduction. Number 2, Hippocratic reduction. Number 3, Milch reduction. Okay, what is the Kocher's reduction? The Kocher's reduction, in case of Kocher's reduction, there are few steps in the Kocher's reduction, which is commonly we can say TEAI. For memorize purpose, we'll say it is TEAI. T for traction. Here, the elbow flexed to 90 degree, arm adducted close to body, then apply gentle longitudinal traction. Next is E. E for external rotation. Slowly externally rotate the arm. It is continued until resistance is felt. Next, TEA for adduction. While maintaining external rotation, bring the elbow across the chest. And step 4 is I for internal rotation. This will occur sequentially. First traction, then we will apply the, after traction, then apply the external rotation. After external rotation, we apply the adduction. After adduction, we apply the internal rotation. After maintaining the external rotation, bring the elbow across the chest. Okay, then slowly internally rotate the arm and the hand touches the opposite shoulder. After this method, the reduction occurs with a click sound. Okay. Next is the hypocritic or hypocrite reduction. Hypocritic reduction. The steps in this reduction or method are same as number 1 is traction. Here holds the patient's wrist or forearm, then apply longitudinal traction force. Then number 2, After traction is the counter traction. The orthopedic surgeon places heel of foot in patient axilla, which acts as a fulcrum in counter traction. Next step is the reduction. With continuous traction force, humeral head slides back in clinoid cavity. With the click sound. So here it is the Hippocratic reduction. Most commonly the reduction used is the Kocher's reduction method, which is steps are the TEAI, traction, external rotation, adduction and internal rotation. And second one is the Hippocratic reduction. And number 3 is the Mills reduction method. Number 3, Mills reduction method. The steps of Mills reduction method, and number 1 is abduction. First is the abduction. Gently abduct the arm to 90 degree, then to 150 to 180 degree, followed by and the elbow kept slightly flexed. Okay, next is the external rotation. Next step is the external rotation. Then after this abduction, then slowly externally rotate the arm while maintaining the abduction. And number 3 steps is the reduction. Here with thumb apply gentle pressure on the humeral head in axilla. Then the head slips back into the glenoid cavity. So this is the Milch method. Most commonly used is the Koch's method. Here next, there is another topic associated with the shoulder dislocation, that is the recurrent shoulder dislocation. Or recurrent dislocation of shoulder. In case of recurrent dislocation of shoulder, there mainly the Hill-Sachs lesion and Banker's lesion occurs. In case of recurrent dislocation, Hill-Sachs and Banker's lesion occurs. Okay. In these cases, Hill-Sachs lesion or Banker's, if there is Hill-Sachs lesion or Banker's lesion occurs during the recurrent shoulder dislocation, we have to go through the surgical processes. What are the surgical processes? Number one is Banker's operation. Here the Banker's lesion is repaired, fixing the detached labrum. Okay. Number two is the putty plate operation. The principle of this operation is to tighten the lax anterior structures by bracing the joint capsule and subscapularis muscle. Number three is the Bristow's operation. In this operation, the tip of coracoid process of the scapula is attached with the muscles is osteotomized and reattach near the anterior margin of glenoid. Okay. So this is the whole topic of dislocation of shoulder. If you have any query regarding this topic, you can comment in the comment section. Thank you.